Resources. As a reminder, we have new meeting protocols in place for 2022 interim session. No remote attendance by members is permitted by the 2022 interim session. All members must attend in person to be recorded as present. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the secretary call the roll.
Senator Adams. Senator Alvarado.
Here.
Senator Berg.
Present.
Senator Carroll.
Here.
Representative Bowling.
Here.
Representative Fleming. Representative Frazier Gordon.
Present.
Representative Gibbons Prunty. Representative Sheldon. Representative Weber.
Present.
Representative Westrom. Representative Wilner. Senator McDaniel. Representative Petrie. Representative Reed. Representative Moser. Co-Chair Meredith.
Present.
Chair Bentley.
Present. So we have enough for a quorum. Representative Westrom said she had a flat tire, so she'll be here in a few minutes. Next, we'll have the approval of the minutes from the August 17th meeting. Do I hear a motion? And a second.
Second.
We have a motion and a second. All in favor say aye.
Aye.
Thank you. Now, the approval of the minutes are done. So this morning we're going to have a presentation from Commissioner Lee and Steve Bechtel, Chief Financial Officer with the Department of Medicaid Services. They will provide us with the fiscal year 2022 closeout numbers and the outlook for fiscal year 2023 for the Medicaid budget. Everyone, please identify yourselves for the record. Members, hold your questions until after the presentation, please. So,
Good morning. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services.
And I'm Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
you may begin.
So just a little bit of an overview of Medicaid. Currently, at a glance, we serve approximately 1.6 million members. 128,901 of those individuals are children covered under K-CHIP. Another 614,000 are covered under the Medicaid expansion portion, and 916,000 covered under traditional Medicaid. I would like to point out that 916,000 does include children who are enrolled in Medicaid. So in total, we have over 600,000 children enrolled in the Department for Medicaid Services. That's more than half of the children in this state. And when we discuss our numbers, we say that it's definitely nothing to boast about, because that means that over 1.6 million individuals in Kentucky live at or below the poverty level. We currently have 69,000 enrolled providers to deliver services to our Medicaid members. And our budget in state fiscal year 2022 was $15.1 billion. That does include both administrative and benefits. And as we get into the Medicaid benefits budget, I will turn this over to Mr. Bechtel, our Chief Financial Officer.
Good morning. For today, we were asked to provide an overview of how we closed out fiscal year 22. I know the last time that we met, I believe it was in June. I believe we gave you through May, at the end of May, and then we projected out what we thought was going to happen in June. So this is, today is pretty much some of the same slides that we presented back in the June meeting, but that we have updated with actual closed out information. But I'm going to try just to touch on the high points to conserve time for the questions and any comments that you all may have afterwards. But you can see there on this slide, it's a side-by-side comparison by fund source. And what I mean by that is general fund, restricted funds, and federal funds appropriations. And we provided you the actual expenditures for state fiscal year 21 and 22, how both years ended up. With 23 and 24, what we've listed there is the budgeted appropriations as listed in House Bill 1 from the session. And you can see there on state fiscal year 22, our actual expenditures came up just short of $14.9 billion. This slide kind of shows you where that $14.9 billion went. You're familiar with this pie chart before. The biggest piece of this, if I can just show you, if you look at it, there's kind of two pieces of this pie, two big pieces, and that's the fee-for-service, which is the multicolored, and then the big blue is from the managed care organizations. Now, of the fee-for-service, that's only what we've spent through fee-for-service is what I've listed here. It is not including some of those services that are paid through the managed care capitation payments. On the fee-for-service, you'll look and you can see nursing facility was the highest at $1.2 billion, followed by the alternative community care. That alternative community care includes our 6 waivers as well as home health and money follows the person program. I will point out again, the all other is just everything other than these main kind of high point services. I listed out nursing facility, hospitals, pharmacy, dental, ICF, IDD, transportation, physicians, and clinics, because those are some of the hot topics that we have going on right now. So I wanted to point those out, but I bucketed everything else in the all other. And the reason why that all other is a negative is because of drug rebate. Drug rebate is an offset of expenditure, so that brings that down to a negative amount there. So you'll see that of our population, we have 90% of our total population that the commissioner was talking about on the previous slide is enrolled in managed care. Of 90%, spends about 80% of our budget, of our benefits budget. The other remaining 10% that is in our fee-for-service is about 21% of our budget. Next slide. So of the amount that was listed on the previous slide for managed care, the $11.8 billion that we had in that slide on that piece of the chart, I just want to point out that is not just capitated payments. Some of those payments are directed payments that we pay through the MCOs as well. That's included in that $11.8 billion in that pie chart. About 22% of that amount is associated with those directed payments. And I've provided you there some of the amounts for the university directed payments, the hospital rate improvement program, which we've discussed in this setting before, as well as the ambulance provider assessment program. And I provided you the amounts that we paid in state fiscal year 22 for each one of those programs. The other thing there at the bottom, I just wanted to point it out again, the urban versus rural on the hospital rate improvement program is 63% of that payment went to urban and 37% went to rural. Of the total $1.1 billion that was paid out in ATRIP, the hospitals did pay an assessment of about $199 million, which the net benefit to them, the net amount coming to them after you reduce it for the assessment that they paid, is about $946 million. We are looking, like I said, in the June, I believe it was in June that we met, and I mentioned that we were looking at adding outpatient to the ATRIP program. I call it ATRIP. I apologize if the hospital rate improvement program is currently just inpatient claims. So we are looking to expand that to outpatient. Early indications is that it'll be another $1.2 billion again on top of this 1.14 that we have here. But the key thing to note here is that 63-37 split between urban and rural. You'll see almost the reverse. It'll be more 60% toward rural and 40% toward urban, because our rural hospitals do more outpatient services than our urban. This slide just breaks it down a little bit more about showing you the increase and decrease from 2001 to 2021 state fiscal year to 2022 state fiscal year. You'll see that our state fiscal year 2022 expenditures increased by close to $507 million over 2021. That's a 3.5% increase. Some of the things that are noted in here is the nursing facility $29 add-on was first implemented just for calendar year 2021, which that goes across 2021 budget as well as 2022. But then we extended that, if you recall, in this last budget, so to include calendar year 22 and beyond. So that's why there is an increase in the $29 add-on for that state fiscal year. It's not $146 million. The $146 is comparing to 2020. If you compare it to 2021, it's about half of that. It's about the $73 million mark that we paid more in 22 than we did in 2021. On the managed care payments, you'll see that that's a 9% increase in 22 over 2021. And I provided you some of the causes of that increase. Some of that is due to increased enrollment as well as programmatic changes. But then I listed out the increase there for the ATRIP program. $364 million for ATRIP was paid more in 22 than was paid in 21. $264 million was paid more in university directed payment, as well as $15 million in the ambulance. The reason why they increased is because of the timing of which those payments are made. In 2021, we went to the average commercial rate on the hospital rate improvement program. But when we process those payments, we wait until the end of the quarter and then process those payments based off of utilization, off of inpatient discharges the next month. Within the month, 45 days within the end of the quarter. So in 21, you had 3 quarters, whereas in 22, you had 4 quarters worth because of that timing and shift there. On the same thing goes for the ambulance directed payment. It was implemented in 21, calendar year 21. So you had 2 quarters in 21, whereas you had 4 quarters in 22, which is why you have the increase there. On the university payment, there was additional providers that qualified for the payment that was brought into the university program. So that's why that was an increase. On this last slide, I just wanted to provide you a kind of similar look between 21 and 22 across our 6 waivers. What was spent on those waivers in state fiscal year 21, as well as what was spent in 22. You can see that we had an overall, in an aggregate, an increase of about $91 million, about a 9.14% increase in total expenditures. There was one waiver, the brain injury waiver, that had a decrease. And when I talked with the director over the waiver, she said it was due to decreased utilization due to COVID in early part of state fiscal year 22, but since then it has started coming back. So that was the explanation I got for that, but that was the only one that had a decrease. The last bullet is to address the 10% rate increase that was in House Bill 1 across those waivers. We are in the process. We've submitted to CMS the spending plan. As you recall, we had a spending plan, but to spend ARPA dollars on other items, but we had that approved. But then during the budget, we were asked to use those funds for a 10% rate increase to help fund for those 10% rate increases across the board on all those waivers. So we had to update that spending plan. It has been sent to CMS, and my understanding we're getting close to an approval on that. But we have to have that approval before we can reallocate those funds. We have to have CMS's approval on how we allocate those HCBS dollars before we can implement that. So once we do that, it will be backdated to 7/1, and we'll be updating that all the way back to 7/1 on those rates. So, 23, you asked Representative Bentley about projections. I provided you the House Bill 1. We have not done our projections. If you recall, last time I said we were going to wait till after the end of the first quarter, and then we were going to be getting together and doing an exercise with the budget director's office to try to do a reforecast and see how we are lining up on our 23 budget. We do think that we're going to need an increase in federal fund appropriations for sure, just because the PHE, when we did the budget back in October of last year, we assumed the PHE would end in March of 2022. So we assumed that those dollars would go away. But since it's been extended, those additional federal fund appropriations will be needed. But we'll be doing that during the session and coming to you guys on that, as well as any increased appropriations necessary for the A-Trip program by going to the outpatient if that passes through y'all's legislation.
How many months do you think that'll be
How many months of what?
before that plan's together?
How many months before?
On 2023.
We should have that. We're going to start working on our projections in, mid-October. We should have that sometime in November.
Okay.
I would say my goal is to have it to you all before, or have it completed before Thanksgiving holidays.
Hey, great.
Yeah.
Okay, question. Okay. Questions? Let's see. Representative Bowling?
Thank you, Mr. Chair. On the waiver, the 10% rate waiver increase, so the state submits that request to CMS, and then CMS approves it or disapproves it for whatever reasons. When does the state actually go about submitting that? Do you all have to wait till the fiscal year to start? Do you have to wait till 7/1 before you actually submit that, or when was that submitted?
That was submitted early on, but I'll let.
That was submitted shortly after the budget bill was passed. And so CMS has a certain amount of days. Typically, it's 90 days to approve or disapprove, or they come back with requests for additional information.
Okay.
And they have come back to the state with additional questions that we have to answer. And we believe that we're close to getting that approval. We've had a couple of really good calls with them the past few months. We can definitely keep you posted on when we get that approval and start dispensing those payments to the providers.
Okay, but I guess the request was submitted before, or I guess shortly after session ended, right?
Yes.
Okay, and I'm just trying to get a timeline because a lot of times we'll go out and tell our providers hey, you can expect this. It's in the budget. As long as everything looks good, 7/1, you should be good to go, and then that doesn't happen, and they come back and say, "What's going on? Why are we delayed?" and all that. And so I'm just trying to learn more on that. But this process, do you all feel like it's gone on a good timeline for getting it turned around?
Every timeline with CMS is a little bit different.
Right,
but we
I understand that.
And we think this is it's going pretty good given the newness of the ARPA funds and the requests that we've made. We think it's going really good. We do have town halls, and we do meet with our members and our providers to keep them updated and posted on activities. We do have a timeline that we can send to this committee that is, I believe it's posted online, but we do have all of our activities, and we have routine email blasts to our providers to give them additional information.
Okay. Thank you very much. Thank you, Mr. Chair.
Representative Frazier Gordon?
Thank you, Mr. Chair, and thank you for being here today. Would you happen to have an update on the application for the 1915C waiver for assisted living? You were going to be having some meetings and working on that during the interim.
We have not submitted a 1915C waiver for assisted living. We did have some conversations. We do currently cover assisted living, a small percentage in some of our other 1915C waivers, but we have not started working on an assisted living waiver, but would be more than happy to have some offline meetings with you to kind of discuss if you want to do that.
That'd be great, because I think we're like one of 3 states in the whole nation that don't currently have that, and I think it would be a huge cost savings and would lead to better outcomes for those that would be able to take advantage of that. So
Be more than happy to have more conversations.
Thank you.
Senator Carroll?
Thank you, Mr. Chairman. Commissioner, can you give us a quick update on the waiver redesign and also on the rate study for waivers?
We believe that the rate study will be concluded later this fall. We do continue to have waiver redesign meetings with various stakeholders. And again, we have a website specifically devoted to our waiver redesign activities. We'd be more than happy to give you a link to that site or give you a timeline of some of the activities that we have done, including provider communications. We could give you some of that information.
Any idea when we'll be completed?
I think that the first step is definitely the rate study, and that again, we believe that is going to be completed this fall, maybe November. I can get a definitive date and give it to you, but we believe that we're on track to get that rate study completed this fall in probably November timeframe.
And throwing you a curveball right now, any idea the cost if we were to eliminate the waivers, Michelle P., SCL, to cover all of those folks? How much the hit would be to the state budget to do that?
To eliminate?
To give everyone the waiver who is eligible for the waiver and do away with the waiting list.
I don't have that number specifically with me. We could do some projections based on the number currently on the waiting list. I think the last time I looked, we had at least a little over 9,000 individuals on the Michelle P. waiting list. But we can give you some sort of a ballpark figure if you would like us to.
And are there other states that don't have a waiting list that you get the waiver if you're eligible?
I can double check with some of my colleagues across the other states. I'm not aware of how they operate all of their waiver programs. Each state has different waivers, so I can check and see if they do have waiting lists.
I just, at some point, we've got to take a big chunk out of this. There are families that are struggling. This is a workforce issue. Kids coming out of high school don't have access to services, can't get the waiver. Mom has to stay home, dad has to stay home. And it's, we've got to take some steps on this at some point and stop this, just picking at it every budget cycle and really making a difference on it. Mr. Chairman, if I might, one more question.
Yes, sir.
Okay, in relation to Medicaid, you said that half of our kids in the Commonwealth are on Medicaid?
Yes, more than half, yes.
Wow. And it's still a third of the overall population. Do you have the difference in that? How much of that third, how much of the total population is children?
We have currently in Kentucky a little over 1 million children under the age of 18 in the state of Kentucky. And of those little over 1 million children, over 600,000 of those are enrolled in Medicaid or K-CHIP. And then going back, if I may, Senator Carroll, to your question about individuals and the waivers and being enrolled, we definitely want to make sure that we can provide services to all those individuals who qualify for our waivers. And currently, if they're on a waiting list and they do qualify for Medicaid, they are receiving some Medicaid services. It's just those personal services that are in the waiver that are not in the Medicaid program that they are not receiving. So they are receiving some medical services.
Okay. I just think it's a good time to really, we did the reimbursement increases, the 10 and 10 and the other rate increases, and then we're looking at the rate study. So likely this will result in more incentive for providers to open more facilities. So it might be a good time to look at next budget cycle increasing those numbers and taking a big chunk out of that. And I know that's something that would be on our shoulders to approve the funding for that. But we got to take care of that population. It's what Medicaid's for. And we just pick at it, and it's not being effective, and families are really struggling. The last question has to do with what I had just asked about Medicaid. Do you all maintain geographic maps to look at where the densest populations for overall Medicaid and for children? And do you all have something like that available?
Yes, we do. We do notice that we do have a higher concentration in the eastern part of the state. So eastern Kentucky has a higher concentration, and the farther west you go, the concentration is a little bit less dense. We have one county which has less than 5% of the population enrolled in Medicaid, which is Oldham County. But we do have those maps, and we'll be more than happy to share those maps.
Sometimes I wonder if economic development shouldn't be more tied to these numbers. If we really want to solve the Medicaid issue, it's all about jobs. And if we focus economic development in the areas of the state that need the jobs, that have the highest Medicaid, we could accomplish a couple things with that. But do you all ever work with economic development? Do they ever approach you about things like this?
I have not worked directly with economic development. I do know that there are conversations between our cabinet and theirs, specifically related to House Bill 7. I believe I've got that one right. As it relates to workforce and sharing of data and information for those individuals who are enrolled in Medicaid.
Okay, very good. Thank you, Commissioner.
And I will say that we do feel like we are an economic engine for the state. For as much money as we are sending out into the state, we're covering a third of the population. Hospitals, it's been well known, been well documented that we would have had several hospitals to close if it wasn't for the HRIP program. So we feel that we are an economic engine.
I want to make a comment on Senator Carroll here. In eastern Kentucky, there's a big need for clinics to take care of autistic children. And so I know of one that's set up, but they couldn't keep afloat because they couldn't get the Michelle P. waivers okay. And they closed.
That really shouldn't have happened because its insurance is now required to cover autism services. Our center's getting ready to open an autism center early next year, and we've ran the numbers, and the private insurance covers it. Medicaid covers it, so we expect a very small portion of our population to actually be waiver
This
payments.
was about a year ago.
That should not have been an issue.
Okay, I'll check into it.
I'd be happy to talk with those folks if you.
Senator Meredith?
Thank you, Chairman Bentley. You're going to see this is probably a strange comment coming from me, but I take a little bit of issue with your statement about Medicaid being the economic engine. I think for rural communities, it's a economic mainstay or economic insurance policy. But looking at these numbers, this is the 6th year I've been here, and looking at the trajectory of the Medicaid program. When I came in 2017, it was $10 billion. Now we're looking at $15 billion. And when you double a program in about 5 years' time, that's something that I think warrants some review. And every dollar we had to put in the Medicaid program means less dollars to put someplace else, like economic development. We're treating symptoms, but we're not really curing the disease, which is the poverty. And we've had a lot of discussions about the Medicaid program not improving the health of our population like it should under managed care. And I'm concerned about the number of people that we continue to add to the program when we're in this supposed robust economy now, creating jobs just left and right. And I would think at some point that we'd still see a stabilization of this budget and possibly even reduce the overall dollars or redirect those dollars to programs like the waiver program, which certainly needs. I think that's the most neediest that we have. But I think we've got to be careful in looking at the Medicaid program as a economic engine. Again, we can't survive without it, but I don't think it gets us the return on investment that we really need if we could redirect those someplace else. So we've just got to be careful with that. But do we really have a focus upon moving people out of Medicaid to gainful employment and insurance under those programs and improving the health of our population? Because we just don't seem to be moving that bar at all. We've had a discussion before. Again, back in 2017, we were 47th, I think, in healthcare outcomes, and now we're 44. But I think it's because we have increased people's access to care to some degree. But to truly say we've improved the health of the population, it just hasn't happened. So I'm not sure how to move this needle, but just want to share that concern. Then just to see it keep growing and growing is a little bit problematic for me. I know we need to have rate increases still for some other providers we hadn't provided for, and we got to ask, where's those funds come from? Again, I think the funds are there. It's just how they are prioritized, and could we not redirect some of these things if we're truly focusing on moving people off of Medicaid and improving the health of the population? So I guess I'm looking more long term, like,
So if I may comment on
well,
that,
certainly.
the trend that you're seeing, a lot of it, we have 2.6 billion of the 15 is related to directed payments. That is due to maybe us being the lower payer. But a lot of provider networks come to Kentucky Medicaid versus going to the commercial insurances to solve their financial woes. So we have done a lot of expanding of benefits through the legislators. You all have expanded benefits on some things. Each one of those that you all approve has a cost tag to it, and that's we're just implementing it, and we're advising you how much it costs. But it's still passed, but we still have to have the budget has to be there to satisfy the law that's been passed by you guys. And I'm just being honest and transparent with you there, Senator Meredith, that we're just implementing the laws that, or some of the benefits that's been passed, or the rate increases that's been passed through budget bills. But at this time, we've also have, due to inflation, due to everything, every provider network that we have, with the exception of podiatrists, have reached out to us wanting a rate increase. And then if we don't get it, if we say, well, we don't have the budget, then they come to you guys and they get it implemented through legislation. So I just have to point that out. Yes, we're growing, but it's due to some of the legislation that's been passed.
Yeah, but in all fairness, part of those increases are supported by providers themselves by increased assessment on them.
Exactly.
So the real expense to us hasn't been that substantial. Right. I don't think you can call that an increase in benefits, it's increase in payments through redirecting those funds.
Correct. So if you'll go back to the slide 1, if I may, the slide 2 back. I think you hit this. Other way. You'll notice there, when you look at the state funds, which is you add the general fund and restricted fund, we had a decrease in state funds in 22 over 21. The biggest part of the increase was those federal dollars that you're talking about. You'll see that we increased $600 million. We only increased a total of $400, but $600 million of that was in federal funds. Now, I understand those are still tax dollars. I'm not here to sit there and hide behind that. I'm just telling you those are the federal funds is the $600 million. That's where the biggest increase is in our budget for this year. But you're right. Restricted funds, that's where the HRIP, the hospitals pay the assessment. We have a new provider tax for the ambulance at 5.5%. That tax funds the ambulance provider payment, the APAP payment that I mentioned. Universities pay a IGT, which is a intergovernmental transfer, where they pay the state match of those payments. But we still have to have the appropriations. Even though they're putting it up, some of that is hidden in those appropriations.
You mentioned the decrease in the state funds over that period. How much is that attributed, or any at all, to the drug rebates?
Well, if I may, on this slide, you'll see the drug rebates right there in 2021 was $827 million. In 2022, it was $1.2 billion was what we received in drug rebates. Now, understand, it's kind of a seesaw effect here, because I don't want you thinking we just got $400 million extra, because in order to get that $400 million extra, we moved from generic drugs to brand name drugs. Because that's all we can get the rebate on is brand name drugs. So when we increase that to increase the drug rebate, we also increase our capitation payments to the MCOs, as well as our pharmacy spend on the fee-for-service side, because we're looking at more high-cost drugs versus the generic versions.
And Senator Meredith, I believe that your comment about how do we improve the health status of this state is one that can't be addressed simply by Medicaid. It's going to take a bigger body than Medicaid. But I do believe that the money that we pay out into the communities in the form of payments to providers does help spur the economy in those areas. But I do think that with Medicaid covering 1 out of every 3 and the massive amounts of data and information that we have, I think if we can just start focusing on how do we use our data, how do we use our information to actually improve the health status of this state, because with Medicaid being one of the largest payers or the largest payer of healthcare services in the state, if we can just harness our data and get it in a usable format to find out how we can change our policies to improve the health status of those that we serve, while when we start moving monies around, what's the impact going to be? Not only how are we going to improve that status, but what's the impact going to be in the provider community? And how do we work with, again, the data that we have and the information to start changing those policies or identifying which specific policy needs to be changed?
Well, it goes back to Senator Carroll's comment, which I think was very well said. You know, the common denominator here is the poverty that we have in the state, and it's just crushing our state, has for years. And I think that's a point that possibly he and I are both making, that if we're really using funds for economic development, particularly our rural communities, we wouldn't have to have such a large Medicaid budget, because we would improve the health of the population and we'd have more people on commercial insurance rather than Medicaid, but we don't ever direct those funds to that area. And I think it makes great sense to have some kind of correlation between economic development and our Medicaid program. And I'm not suggesting you folks start having weekly conferences with those people, but I think as a legislative body, we have to start formulating policy to address those particular issues. And a couple of us went to a seminar back in April, talking about payments based on deprivation values, and I think that's something that ties into what Senator Carroll's saying as well, that the economic development of this state really should be directed towards our poorest communities and give an opportunity to lift those people out of poverty. And when that happens, everybody benefits from it, because we lift up people out of Medicaid and it makes funds available for other purposes, but we don't think that way. It's almost like it's upside down, and that's not your fault. That's more, I guess, our fault that we don't make this a priority, which we should. But thank you, Mr. Chair.
Thank you. Senator Byrd.
Thank you, Mr. Chairman. Do you all have this is a follow-up to Senator Meredith's question, a sense, excluding the children, obviously, what percentage of the Medicaid population in this state is employed?
We don't have those numbers, but we can get those through our eligibility determination process.
I think that's a really important number to know for the purposes of this discussion, because I can promise you that every 30-year-old I know who is fully employed is now covered under Medicaid. These kids can no longer afford to pay for private insurance. So, when we're talking about economic development, one of the things we have to think about is, are the jobs that we're offering in this state good enough for these younger people to be able to cover their own health insurance costs? Or is that something that's going the way? Because in my experience, it's going the way. So I would really like to know how many of the people that we cover under Medicaid in this state, adults, are either unable to work due to medical or psychiatric, whatever, or are actually fully employed. Because the majority I know are fully employed. Thank you.
Representative Moser.
Thank you, Mr. Chairman, and I appreciate this discussion. I think that we all have the same goal here, and I think we're having some really good points that are being discussed. I agree completely with the economic development connection. I've said for a long time, if we don't have a healthy population, we really can't grow economically. It affects everything we do. It affects our education, our obviously our healthcare system, our criminal justice system, and so forth, workforce. I'd like to make 2 points, and there's probably a question in here somewhere, but we're talking about a lot of different things. I mean, rebates were brought up, and that's the 340B program, and we have to spend more to get more, and does it really make sense? But you talked a little bit about the data that the cabinet collects. Is there an audit that you all do on a regular basis to kind of address some of these questions, joblessness, or how do we look at this and tie it together with our lack of health here in the Commonwealth? We have passed, to your point about expanding Medicaid, we've passed some legislation that I think targets our Medicaid dollars toward programs that really work, and it may take some time to really see the return on investment. So I don't want to say, that we're expanding Medicaid, because the whole point is to get people back to work, to make sure that they are, that we have a healthier population. And so, if there's an audit of some sort that the cabinet could take on to really help us prioritize what we spend our Medicaid dollars on, what's working and what isn't. And there are a lot of factors that go into that, I understand. But I think that would be important, because, we had House Bill 525 last year, which are community health workers, which we, are probably likely on the front end spending more. But the whole point is to get the spend down on Medicaid in the long run. House Bill 7 addresses some of the eligibility requirements and ensures that Medicaid is the safety net for the population who really needs it. And so, that all ties to the waiver programs and how much we can spend. So, again, I think you're right, Commissioner Lee, that we need to really look at our data and have it work for us. But we need to do that together. And I think, the Economic Development Cabinet should absolutely be part of this conversation. And then, if I may, Mr. Chair, I've got one more point. We had a work group, we established a work group last year to talk about bridge insurance. And the whole point was, how do we really operationalize some state dollars with a private sector match through employers? And so we started talking about, whether or not we can use TANF funds, or, to kind of create a pass-through through employers and getting people back to work, so that folks, we're not fully subsidizing with Medicaid dollars, but we can, I'm just trying to figure out a way to get creative with a public-private partnership to get people back to work, to provide benefits. And at the same time, I think we could really use, we've talked about the benefit cliff. I think that plays a big part in whether or not folks can move ahead in their employment. They can get raises without losing all of their benefits. I think there are ways, and we've seen, we've talked to the, Georgia Center for Opportunity and some other organizations who have modeling programs that can really help identify when an individual is about to fall off that benefit cliff. Are there ways to stair-step this so that we don't have that benefit cliff? We allow people to get back to work and stay employed and move ahead in their employment, and eventually move to independence and self-sufficiency. I think that's got to be our goal. We have the marketplace now, and so the question is, how would that be different from the marketplace? I guess I see it as a P3, and it would absolutely move people off of Medicaid eventually. That would be the point. Right now, I don't see that there's a real mechanism in the marketplace to move people off of Medicaid. So I hope that made sense. Somehow we landed on a basic health care plan, and that wasn't really my goal. So I hope that we would revisit the bridge insurance and tying the benefit cliff modeling program into the conversation more than just another health insurance plan through Medicaid. So there's no question in that. You can just, take it for what it's worth.
Well, if I may comment, one thing,
thank
when
you.
your very first comment of spending more to get more on the drug rebates, we are looking into a report, doing an analysis of Senate Bill 50. We should have that report done soon. I'm not sure a timeline on that, but it should be within the next 4 to 6 weeks. We should have that completed to kind of show the savings, because I don't want you to think there's not a savings. What I meant by saying is that we would there's a kind of a seesaw effect, like I said, that some of the expense, I don't want you thinking that full amount of the $400 million of drug rebate is all savings, because there is an expense tied to that amount as well. Okay, I just want to clarify that, make sure everybody was clear.
Senator Alvarado.
Thank you, Mr. Chairman. I've got a few questions, if you'll indulge me, and just a few comments. So first of all, Commissioner, thank you. I also want to appreciate the fact you're very prompt in your responses always. And you get a lot of my little semi-rants and complaints from providers. You're always very prompt in your responses, and you always follow up. I really appreciate that, so thank you. Okay, so a few things on this. One of the first, and some comments on some of the things that have been discussed here today. We know that we have extra enrollees, obviously from the state of emergency federally. Is that going to affect the budget numbers that we see here as those get disenrolled? Has that been put into the numbers and the pie charts that you've given us? This is just a closeout, I know, from last year. But I guess going forward, is there a projection as to when they decide? And again, there's some confusion even at the federal level as to whether or not we're still in a state of emergency or not. So assuming that they determine that, hey, we're going to remove that and all these enrollees now come off the rolls, how much will that affect our budget from what we can estimate?
When we did the budget projections back in October of when was it that I did that? 2021, I think. You all voted on the budget in this past session. So we had to have those done by November. And we made the assumption at that time that the PHE would end March 31st of 2022. And at that time, we would have a 1-year time frame of doing redeterminations where those people would come off the rolls. So that's what's in my projections for the 23 budget, but that's not what was realized. So it will have an impact on the budget.
Okay, so do we have an estimate as how much that's going to be?
That's what one of our goals, our task in that recalculation that we're doing in October. And we should have to you all by the middle of November.
So I know it's, roughly what we pay per member. And again, the number that always goes through my head is about $600 per member per month, roughly 200,000. You're looking, it'll be in the billion, probably over $1 billion for the year. It could be a significant impact ultimately.
Total dollars, yes, not state dollars.
Right, correct. Total
Right.
dollars.
Total dollars would be over $1 billion.
Sure, okay. And that's what we're looking at here is total dollars to the Medicaid.
I'm looking at total, but I
Yeah.
broke it up on those other pages by the state and federal. But until we do get a 6.2%, not on just those 200,000 members, but we get to 6.2% on all members, the members in the program of the traditional program. Mm-hmm. We don't get it on. We get a little bit bump on CHIP, like 4.34%. But expanded adults is all at 90-10, but we do get a 6.2% enhanced funding on all, not just the 200,000 that are going to drop.
Right, and I had a question at an earlier committee meeting last week, I believe, with Commissioner Cecil, and asking, hey, is this a mandate from the federal government? It isn't necessarily a mandate. We can say we don't want to do this, but it's profitable for us, effectively is the best way to put it, is that there's more money coming from the feds to keep a lot of these folks enrolled until they tell us that they've got to be off the books, so they're no longer going to cover it. So I think that 6.2% goes to that it becomes, there's more money in Medicaid as a result of that. Would that be fair to say?
Well, we did, after your question at the last committee meeting, we did go back and research to make sure that our understanding was correct with the public health emergency ending and the 6.2. So we have to keep everyone enrolled until that public health emergency ends in order to maintain that 6.2. And if we, for example, said, well, we're just going to start disenrolling now, we would have to go back to the beginning of the public health emergency and give those funds back for the 6.2. So you are correct that the 6.2 is more profitable than disenrolling.
Okay, so and that was what I was trying to get at. Was I wasn't sure it was a federal mandate, like you have to. You don't have to, but it's obviously they've made it very difficult not to. Effectively, is the way I want to put it there from a financial angle. Okay, on the pharmacy costs, I know that you've got kind of in your pie chart there of 122.9 million on pharmacy. Is that lower, higher than what we've seen in the past after we've kind of brought a single PBM into? I would imagine that reflects a lot of that cost for Medicaid. Is that a higher amount, lower amount since we've done that?
So the pharmacy spend, and Steve will have to correct me if I misspeak, but the pharmacy spend of 122 million is only for our fee-for-service population. So when we move to the single PBM, we still have the managed care organizations paying those pharmacy claims. We just administer the benefit.
Okay, so that amount is buried into the blue, under the
Yes.
MCO
Yes.
amount there. Okay. I think you had mentioned about the rebates and how, again, there's a higher amount. Again, is that something that we were even in the past prior to the single PBM? Is that different since we've gone to that model, or?
The rebates?
Yes.
Yes, it's substantially higher than what we've had in the past.
In the past, where did that money go? Was it just?
These are all offset of expenditure, so we have to pay the federal share back of those. So it's about 80% goes back to the feds, and about 20% stays here. So we use that 20% to offset. Where it's an offset of expenditures, it's just that we're not using our general fund or our restricted funds as much.
Got it. And the point I'm getting at is those rebates were going to our MCOs before. Often weren't reported in medical loss ratios. I would imagine that was the issue that we had. Was there's an MLR of 10%, and when we had those folks here before us in the past, they said, well, we don't know. We turn it over to a PBM. The PBM, I don't have to answer to you. And those are savings that were going to some. It wasn't going to consumers, clearly, because they don't have to pay anything. It wasn't coming to the state. So I'm pleased to see that.
So we're hoping that the report that I mentioned on the Senate Bill 50, the analysis that we're doing, will kind of help you illustrate some of that for you.
Sure, that'd be great.
Senator Alvarado, let me ask him a question on that. Are you going to pay pharmacists more out of that?
We currently, so part of the single PBM in Senate Bill 50, we pay, we increase the dispense fee to the pharmacies. It moved from a varying rate that the MCOs paid to a flat $10.64 for each prescription. So they are getting more money in that. We do. It's a very complex, complicated program, but they are receiving more money in dispense fees than they were under the old formula.
As well as the ingredient cost, obviously would be higher. So they'll get paid that ingredient cost.
Senator Alvarado, sorry.
Thank you, Mr. Chairman. So to that point of increased savings when we brought things back underneath our own tent, it prompts me to ask the question, and I think the commissioner knows where I'm going with this. I've got a lot of providers who are looking back with some nostalgia of how things used to be prior to our MCOs being part of our process. And I know we've had the discussions of, well, boy, it just would be so much administrative cost, and it's just easier to give it to a big group and to manage a lot of this. And I often talk about them not managing care; they manage money more than they manage care. Our Department of Medicaid, I think, tries to manage care truly, and they have to manage funds as well. That's part of it, but there is an attempt to try to improve care and provide that for folks. So it prompts me to question. We're looking at the budget now. The amount that goes to managed care is $11.8 billion. They have a 10% MLR, a medical loss ratio they're allowed for administrative costs and to administer the program. That's about $1.18 billion. If someone were to say, hey, we're going to bring this whole program back underneath the state's purview, remove the MCO model, let the state manage it, and you could use $1.18 billion to manage the program, would that be something we could do? Because I have to wonder, if we found savings when it comes to pharmacy, we would probably realize very similar savings when it comes to the managing of care for the system. And that's what we're paying a lot of these companies on an annual basis, is $1.18 billion to manage this, with the complaints, Commissioner, with the emails you get from me from lots of different folks, and problems that continue to happen there. And that's what I'm wondering, is that something you think we might be able to do, or could we study to see if we could do that?
Well, Unfortunately, I don't think I can answer that question. I do think, study. The bulk of the states do use managed care organizations because it does promote budget predictability. The other thing that the MCOs have is flexibility. Some of them do cover value-added services, and they have ways to communicate with their members and get those members, for example, pregnant women. A lot of the MCOs give car seats and strollers to their members. That's something Medicaid in a fee-for-service world would not be able to do. The other thing that we would not be able to do that would be a major impact is the HRIP and the programs. So we would not be able to do those directed payments. And again, it's not something that I could answer, would be comfortable answering without a more in-depth study to look at other states and have other states gone from a managed care to a fee-for-service arena, and if so, how does that look and what were the implications and the unintended consequences maybe. But something definitely I would think that a study would need to be.
If I may, I
Sure.
don't mean to interrupt you, but the part of the directed payments is the average commercial rate. If we pull everything back into fee-for-service, there's a UPL, an upper payment limit, that we cannot exceed. We can only pay up to the Medicare amount. Some providers have negotiated successfully with MCOs to negotiate a rate higher than our fee-for-service rate schedules. Some have not. Most have not, but there are some that have. They would experience a rate decrease, as well as we would not be able to, like she said, on the HRIP and the university directed payments. We do those at average commercial rates. Those would be a substantial decrease in those payments because it'll go back to the Medicare UPL.
Yeah, maybe. And again, I tell you, I know a lot of providers who remember how it was in the old days, and they complained back then. Believe me, I know how providers are. I'm one of them, but it was a lot less than what we're encountering now. Just the efficiencies were different, and it's again we've created and again we've been innovative in creating our single PBM model. A lot of states are looking at what we're doing here, saying maybe we need to do the same thing. I don't mind trying to be a leader and try new things. It'd be worth looking at, I think, really, just from where things have gone, because how many bills have we passed here as a General Assembly to try to bring in business partners that we've partnered with to do the right thing, and they just try to find ways around it and don't follow those things. That's not somebody I'd like to do business with. I mean, I wouldn't be doing business with them. And I think if the state can do it better, and we've done it better when it comes to pharmacy, I think it'd be worth looking into, and especially if we could say, hey, maybe you get a single repository of someone who can do a lot of the things that you're talking about, but for $1.18 billion, it's a lot of money to be able to manage a system that often has to come back to you all to try to figure out and kind of do those things. I just think it's worth the discussion and worth looking into, that maybe what's old is new again, and it might be worth looking into just from that standpoint. I know we were talking about rate to providers also, that's obviously a big thing. I know we've had I think some of the discussion, we've had an increase in probably a 25% increase in overall budgetary expenditures for Medicaid in the last 3 to 4 years. I don't know that that's all from us passing bills to increase $3 billion worth of expenditures on that. I want to make that clear. I know a lot of it is an expansion of Medicaid during a state of emergency and a pandemic and those sorts of things that come through. So it isn't, I think we're very careful. There's a lot of programs I'd like to expand and do things with, but once I get my fiscal note, my legs are taken out from underneath me because we can't afford it is often the commentary, where are you going to get that money from? But so a lot of it hasn't necessarily come from us. There's other factors that have increased those as well. And then, Commissioner, to your point about collecting data, I mean, we've had having some discussions about an all payers claims database and discussing what that would look like. I understand that there is an organization that currently has a lot of that information for Medicaid, which is Greenwell Technologies, is my understanding. If they have a lot of it, they don't gather it and compile it in a way that can be read, but that they have kind of that data in a kind of a jumbled, kind of like how it was when we tried to get the PBM bill. They reported all the data as a jumbled mess, and we had to try to figure it out. It's in that kind of a state. So there's been some discussion saying, hey, look, the data is somewhere. It's just a matter of compiling it in a way that we can report it, that our data people can interpret, that our universities can look at it and interpret for the purposes of trying to drive better medical care. I know we've had that discussion with our MCOs here before. And when we said, show us what you've given us for the billions of dollars we spent with you for improvements in our overall outcomes, and they struggled to come up with any kind of viable numbers. And then afterwards, the discussion was, well, you tell us doctor, you guys, General Assembly, tell us what you want us to improve on. I said, well, you all are the ones that are managing the care. You know, if you're going to have us do it, I often question, why are they there? But if they're wanting us to tell them what to drive for care, then we need that data, to your point. And so I think we're working on some of that. And we're going to get some language together, try to get input from the cabinet, from Medicaid as well. We may have to start in baby steps, maybe start with Medicaid first to help us drive a lot of that and collect it. But those are the things I wanted to just comment and throw out there. I appreciate you all coming with this. And, like I said, I appreciate your responsiveness with a lot of the issues. Commissioner, I really do appreciate that. Thank you, Mr. Chairman.
Thank you, Senator. Representative Westrom.
Wow, I wish I hadn't had a flat tire this morning. You guys always have so much important information. I walked in when we were talking about providing jobs to more people in the state of Kentucky, which would reduce the Medicaid budget. And I know the Medicaid budget has continued to rise. I also know that when I first moved to Kentucky 30-some years ago, I lived in the 6th poorest county in the state. And if you talk to an EM person at that time, they just couldn't wait to get out. So I am wondering, you probably have the information, but I don't know if you've sought it out to look at it diagnostically, but what has the population shift been from some of these rural counties that really have not had the opportunity to have very strong employment numbers because there is nothing? And how has that shifted the Medicaid budget in those areas? That's an easy job, isn't it?
Yeah. That is a very simple job. I think Senator Carroll asked the question too, if we have the Medicaid population mapped out by county and the density, and we do. We can look at that, and we can also look at, because we have that information already, the population density. And I'm not sure when you say the shift by county over time, if you're looking for, a 5-year, 10-year look back and how that population has changed. But just based on my personal experience, I don't think that the population density changes that much. We continue to have the largest population in eastern Kentucky, but we could, definitely pull together a map of the employment of the state to try to see. But we do know that the population is, the highest population is in eastern Kentucky of the Medicaid population. And again, coming from eastern Kentucky, I know a lot of the challenges they face in that area with access to care, transportation, other things like that. So, but we'd be more than happy to get that map so you can see the population density.
Senator Meredith.
Thanks, sir. Just a quick comment and a question. Commissioner Lee, temporarily, you kind of had that deer in the headlights look whenever Senator Alvarado talked about bringing this back under Medicaid, and just wonder if you think maybe might be able to limit the number of MCOs, make it a whole lot more attractive now. You think? Maybe not.
I think that a study is good, and again, I go back to, I'm not sure that the number of MCOs is important as how we hold them accountable and making sure that we're getting our return on our investment and we have something to measure their success. And I think that that's one thing that has been lacking quite a bit, is we don't have a baseline to measure where we were and where we're going.
I would agree, and I appreciate that. The question I had is for Steve, actually. You made a comment earlier, and I'm kind of paraphrasing you, about how the commercial insurance market has now kind of relied on Medicaid to kind of subsidize the system. And I'm kind of paraphrasing this, but back in the old days, we did cost shifting. Everybody knows that Medicare and Medicaid didn't pay the full amount, and you expect the commercial insurances to pick up that difference. And nobody argued for that for years until we got a very competitive market, and folks said we're not going to do that anymore. So now you've got situations where there's nobody to do cost shift to, and that's caused a lot of demise of the financial positions of rural hospitals. But it goes back to, I think, access to the insurance market. And that's to Senator Berg's question earlier about, young people can't find insurance. Part of it is the market's still very, very tight. Do all 6 of our MCOs also offer a commercial insurance?
Do you know that?
believe they do. Yes, I believe they do. And I think I'm going to have to get my poker face when I come into these meetings from now on. But I think what we're talking about with Medicaid, Medicaid has become the go-to program to solve some health care issues that commercial carriers either will not or cannot. I mean, we cover more than half of the children in this state. Our child benefit package is so robust that we cover so much that private insurance doesn't cover. We don't have limitations because of our early periodic screening and diagnostic and treatment benefit. We don't have limitations for our children. And some of the saddest stories that I heard was when I was working on our member services call line. Medicaid is based on a poverty scale, and that $1 means you don't qualify for Medicaid, and you can't go from that $1 and having your insurance to not having any. And the saddest calls I had were from parents who are working and their children were on Medicaid. They either had autism or they were asthmatic, and they could not afford to get off of Medicaid because they had to keep those services that Medicaid was providing because, number one, they couldn't afford commercial. And if they could afford commercial, there were limitations and higher out-of-pockets that they couldn't afford the payments. But private insurance, we have children who are on private insurance who do not qualify for Medicaid but are on waiver programs because private insurance does not cover the services those children need. We cover 70% of the long-term care costs in this state. We are the only program that covers those home and community-based waiver services to allow individuals to remain in their home and community rather than going to a long-term care facility. So when we talk about Medicaid being the go-to to solve those issues that commercial carriers either will not or cannot, that's what we're talking about, and that's why we see a large, I think, increase in utilization in services, because we cover so much that commercial carriers can or won't.
And I think that's the point I was trying to make, but didn't ask the question very well. I think we've got to find some way to make the distinction between they won't or they can't, and I think it's more that they won't, and it shouldn't fall back to the Medicaid program to provide that service, and maybe that should be a condition of participation in the MCO program. Is you got to offer something comparable on the commercial side. But thank you, appreciate it.
Thank you, Mr. Chairman. I don't think WellCare offers private insurance. We're going through that exercise now, and I don't think WellCare does. So it's not all the MCOs.
We can go back and double check.
Yeah, and I may be wrong, but I know we're communicating with them, and which is a whole different conversation, trying to get contracts with private insurance carriers. The question on the benefits cliff with Medicaid, that's every year that I've been here, that's been a source of conversation. And I know we passed, I think last session, where it's like extended a year, maybe there is some assistance in that area. Do we maintain numbers as far as each year of the people that are right on that edge? That is there any way to get data like that to really determine? I know I have employees that they don't want to raise because that's going to put them over the edge and they lose their benefits. Can't blame them for that. They got to take care of their kids. But do we have any idea what those numbers are in the Commonwealth? How much benefit it would be if we did put in some type of step away from Medicaid where it was a gradual process rather than a cliff? Have we studied it that closely?
I don't think we have studied it that closely. And Medicaid is, of course, an income-based program, so we do have information on household income in our system. Some of those numbers fluctuate. For example, individuals who are self-employed, sometimes they're a very we're concerned about our self-employed because their income fluctuates on a monthly basis, and depending on how their income flows, they could be on Medicaid 1 month or 2 months and then off and then back on. That's the churn that we talk about in the Medicaid program, and there are policies that we could put in place to prevent that churn that would help individuals maybe move out, such as continuous or 12 months continuous enrollment, those sorts of things that we could look at. But again, that 12 months continuous enrollment means 12 months continuous enrollment.
we've seen, even though there has not been a formal increase in the minimum wage, there without question has been an informal increase in the minimum wage to be able to get any employees. So, figuring that in, I'm curious if, how many more people that put on that edge by, instead of, $8 an hour, it's now 11, 12, 13 is what they're starting everyone at. And I wonder if we created more issues by doing that. But that's just a whole line of thought. And that phasing out Medicaid, that I think at some point that's really something that we've got to take a close look at and make some permanent changes on that where people can phase out of it, because we talk about that all the time, that getting them employed and then getting them to work up that ladder to where they are independent, but we really don't give them, we say we want them to do that, but the system's not set up to encourage that, because they don't want to lose the benefits because they have to take care of their families. And there's a lot of industry in the Commonwealth that is at that level where, you're right on that verge based on what they pay. And one final question that I have, we talked about the programs that MCOs do to improve the health in the Commonwealth, and that we wouldn't be able to do that as well. How much control do you all, as Medicaid, do you have over what I see seems to be more programs to encourage it's more marketing efforts? And I'm not saying that in all cases. There are some really good programs out there that are really beneficial that the MCOs do, but a lot of it is geared towards marketing. And do we dictate, or do we approve, or do we discuss with them what programs they implement outside of paying the providers to improve the health care within the Commonwealth and the outcomes?
We do have to approve their value-added services. So we do have we'd have quite a bit of input into that. We also have performance improvement projects that they participate in. We have a quality improvement strategy that they have to, we pick certain programs or certain projects that we want all 5 MCOs to work on together. And then we have, for example, an asthma or diabetes program, improvement program that we ask them to work on, and then they have some that they can work on themselves that they can choose to work on. So we do have quality improvement strategies and projects in place for the MCOs.
Thank you. And I love these discussions. I just wish we could get the rest of the legislature in line with what we discuss in here to get some things done. But really good discussions, and there are pathways forward to improve this Commonwealth, and a lot of it's on our backs to make those changes and to be bold and make decisions that are going to change us, because it's, the time I've been here, it's not changing. And and it's no criticism on you all. You all do a great job, but we've got to look at the whole picture in this, and we've got to make some substantial changes to get on the right path to truly make a difference, and again, stop picking away at it. Thank you, Mr. Chairman.
Thank you, Senator. We got a hard stop in 10 minutes. I always wanted to tell Representative Moser that. You're next to speak, Representative Moser.
Thank you. I just had a quick question about the 12 months of continual coverage. Is that a federal requirement?
It's an option that states can do. Some states do have 12 months continuous eligibility, and sometimes they will use it for specific populations, such as children. They'll have 12 months continuous eligibility, which means that child comes in and they have continuous eligibility for 12 months before they have to do a recertification. So,
but is this for the eligibility, for the individuals who kind of churn in and out of eligibility? Is this, I'm trying to decipher who this is put in place for.
Currently, when an individual enrolls in Medicaid, they become eligible for Medicaid. If anything in their household income changes, they have to report that to the department, and if their income increases over the limit, then they would be disenrolled. And there's no specific time frame for that. With continuous eligibility, regardless of that change, they would remain enrolled, and that would reduce the churn in and out of Medicaid, particularly for individuals who may have fluctuating income throughout the year.
So, if I may, ask just to follow up. So, does when the eligibility or when the income is fluctuating, does that change the amount of Medicaid dollars that person is eligible for? Or is it's just a basic flat? You're enrolled.
Right, yeah, so
Gotcha.
if their income fluctuates and they make too much, they're just off of Medicaid and they have no benefits.
Yeah. So I'm back to the benefit cliff and this modeling program that I think would be really beneficial if it were internal. I know that there are some other organizations who kind of look at the information about maybe general pockets of the population who fall in and out of eligibility, but we don't have an internal system that really models that the program, or doesn't look individually on an individual basis at what a person's dealing with in the, as far as the benefit cliff, like where they are. And that's why I brought, and Georgia Center for Opportunity is probably one example of a few operations or organizations who do this sort of modeling. But I just think it would be so helpful to take a look at what individuals are really dealing with, and we could probably adjust our Medicaid subsidies, our benefit subsidies. I just think that we need to get creative around this population.
Thank you. So speaking of the benefits cliff issue, Kentucky has the KI HIP Integrated Health Insurance Premium Payment Program, which is offered to eligible policyholders to help pay for the cost of an employer-sponsored insurance plan. So is that something that is offered frequently, or is it proliferating, or can that be a key in helping us transitioning these people to private employer-sponsored plans?
Yes, so the KI-HIP, I don't know if I call it KI-HIP or K-HIP sometimes, but that is a program that Medicaid will pay insurance premiums for individuals who have insurance through their employer. We pay their premium for them, and then we will pay any wraparound services that insurance doesn't cover. But we have been promoting that. We promoted it across, of course, at the state fair. We had information. We do reach out to individuals who are employed to find out if they have health insurance or opportunity for health insurance, so we can pay their premium, because it does reduce costs for Medicaid when we pay their premium. So we do have active outreach campaigns for individuals. One of the issues that we find is, even though some individuals are employed, they may be employed at a part-time basis, so they don't have access to the insurance, or their employer doesn't offer health insurance. But for those individuals who are in Medicaid who have health insurance through their employer, we do outreach to them and give them the option for us to pay their premium for them. And we have increased those numbers quite a bit over the few years since we've been advertising that program.
Okay. We've had 13 people ask questions today. Isn't that great? I'm the 14th, and then we're going to adjourn. Yeah, I don't want to leave on 13. I have a micromanagement question. On university-directed payments, is that like going to a UK hospital?
Yep. It's going on the university direct payments. It goes to UK, U of L, Jewish, Norton's, and King's Daughters.
That's what I wanted to ask. Since UK became a partner with King's Daughters, they get paid through this program rather than through KDH.
They do not get through the HRIP program. They can't get both. So they do not get the HRIP program, but they do get through the university directed payment program.
So that's where their payment comes from. Okay. I'm glad to see you bring up that SB 50 analysis. And as soon as you get it, I'd like to see it.
Yeah, I would like to see it too.
But just a small comment. I've dealing with drugs all my life. You talked about trade unions having a higher value, like on AWP. Well, that rebate would be higher, but in today's market, a lot of generics are only priced 2% under that trade name. And so, that's neither here nor there. So
I know that when we make a decision, if we're going to do a generic, I'm not involved with that. We have a pharmacist
When I was in business, I dealt with 3 Medicaids: Kentucky, Ohio, and West Virginia, and they all were different.
Yeah.
And it's good to look at other states and see what they're doing also. Okay, before we adjourn, members, please note that the next scheduled meeting is October the 19th with Chairman Meredith. So now the next item is adjournment. Do I have a motion? Thank you.